Thank you, Professor Yu. I think in the interest of time, we'll now move on to the next lecture. Please allow me to introduce Professor Catherine Fan, Consultant Cardiologist in Cardiac Medical Unit, Deputy Hospital Chief Executive of Grantham Hospital in Hong Kong. She will discuss sudden cardiac death and guidelines for ICD implantation. Professor Fan, please.
Thank you. My deep apology for the my technical issues, but I hope you can see. Can you see my screen?
Yes, we can.
Great, thanks a lot. My given task today is talk about sudden cardiac death and ICD guideline. Actually, this is a very huge topic, and I'm trying to squeeze pick up some salient points, and hopefully we'll have some sort of in-depth discussion afterwards. Hang on. So sudden cardiac death or sudden cardiac arrest and its most common consequence of sudden cardiac death actually account for about 50% of all cardiovascular death worldwide. Survival statistics for the out-of-hospital cardiac arrest remain very disappointing, approximately 10% overall survival rate. And the greatest challenge we're now facing is trying to identify the relatively small high-risk subgroup concealed within the large general population who have no identified disease but are at risk of sudden cardiac death at their first cardiac events. This two diagrams actually comes from the 2017 AHA-ACC HIS guideline, and indeed the showing that the sudden cardiac incidence is highest is lowest in the general population group considering the denominators. But our task is now trying to find the high-risk group, as well as we now know that it's the heart failure patient or cardiac arrest survivor, and looking out for risk stratification. Is this the high-risk group we try to identify and how to improve their outcome? The major etiology of sudden cardiac death are listed here. Mainly predominantly is ischemic heart disease or any involving the coronary or the aortic disease. The non-ischemic heart disease are listed here, like dilated cardiomyopathy, hypertrophic cardiomyopathy, arrhythmogenic RV dysplasia, and some congenital heart disease, especially the post-repair TOF or the Epstein patient. Of the therapies currently available to prevent sudden cardiac death, we know that ICD is now by far the longest standing and best supported by data from clinical trial and regulations. And how the ICD function, I think if you this will be go into more details either in today's and then the subsequent lectures about 2 weeks later. But very briefly, it monitors the heart rhythm continuously. And when programmable rate is met, or when what physician define as tachycardia, it will detect it either VF or VT. If programmed, sustained SVT discriminator is on, it will further classify the tachycardia SVT or VT, and if confirmed, the therapy in form of ATP or shock is being delivered. The multiple randomized multi-center clinical trials have contributed and established the role of ICD as mainstay in treatment of ventricular arrhythmia and sudden cardiac death prevention. In this diagram, you can see the first. Those studies shown here are the sort of landmark study for establishing our secondary prevention criteria. And those in the middle, as highlighted by the yellow arrows, are the patients who have heart failure or left ventricular dysfunction alone, but no documented ventricular arrhythmia beforehand. And these are the high-risk group we indicated as primary prevention. These are the few studies actually indicate, well, not that significant benefits from ICD, namely those who require revascularizations and shortly after coronary interventions. So this is the two landmark trials on primary prevention ICD, and both of them use left ventricular dysfunction as the main criteria. In the MEDIT-2, published in the New England Journal 2002, is ejection fraction of less than 30% in MI patients. And in the SCUT-HF trial, prophylactic patients, New York Functional Class 2 or 3 with ejection fraction of less than 35%. In this group, they include both ischemic and non-ischemic. Both demonstrated significant improvement and reduce of sudden cardiac death in the ICD group. Accordingly, over the years, guidelines has been written and updated, and I'm going to concentrate a bit more on the most recent one, on the 2017 AHA-ACC HRS guideline for the management of patients with ventricular arrhythmias and the prevention of sudden cardiac death. This is a very well-written paper, and it actually starts with a lot of therapies recommended when we are treating patients considered high risk of sudden cardiac death. Mainly, we have to titrate heart failure therapy, evaluate for ischemic heart disease, any possible anomalous origin of coronary arteries, and the further additional management of the monomorphic VT refractory antiarrhythmics, and whether we should consider catheter, surgical ablations, and even autonomic modulations. These are all the adjunct therapy or you need to think about if you have a patient being considered with heart failure or ongoing ischemia and consider high risk of sudden death. And I'm going to pick up just the two main group of patients we considered a high risk of sudden cardiac death. And this guideline actually spent a lot of pages and content on this specific disease state. The first of all is the ischemic heart disease. Here listed the secondary prevention of sudden cardiac death in patients with ischemic heart disease. And it's all pretty well, I will not go into details, but it's all pretty well written out, either survival of sudden cardiac death or hemodynamic unstable VT. You have to look at the risk. All these are an ischemic heart disease with unexplained syncope and inducible VT on electrophysiology. These are all class 1 indication. And this is the flow chart. So either it's a sudden cardiac death survivor or documented monomorphic sustained VT or patient with cardiac syncope with low ejection fraction. So this is how the secondary prevention of ischemic heart disease flow diagram is shown very well, simple and illustrated here. The primary prevention of sudden cardiac death in ischemic heart disease are listed here. Basically, if you look at ejection fraction of less than 35% or less due to ischemic heart disease who are at least 40 days post-MI and at least 90 days post-revascularization, New York Functional Class 2 or 3 despite guideline-directed medical therapy. The second one is ejection fraction of 30% or less, ischemic heart disease who are at least 40 days post-MI, at least 90 days post-revascularization, this time New York Functional Class 1. This is also given a Class 1 indication in this guideline. On top of that, we need to think of, if you think of patients are significantly high risk, due to VA, then you need to think of the values. You need to really go for the values of identifying high-risk patient. Then here is the non-sustained VT due to prior MI, ejection fraction 40% or less, and inducible VT or VF at EPS. So this is also another Class 1 indication. Kindly remind you that all Class 1 indication has this additional criteria of meaningful, if you think that there's a meaningful survival of greater than 1 year is expected. 2A is patients of ischemic heart disease, functional class 4, who are candidates for cardiac transplant on an LVAD. So here, ICD is considered reasonable as a bridge to transplant or mechanical circulatory support. However, for class 3, which is not indicated with no benefit, are those patients who are considered class 4 and medical refractory heart failure, who are not also candidate for transplant, LVAD, or even CRT defibrillator that incorporate both pacing and defibrillation threshold. So class 4 with no indications of further advanced heart failure therapy, is a class 3 indication. And this actually, I'm going to then go to talk about probably associated with under the heart failure section. They look into patients with reduced heart failure, again similarly for waiting heart transplant, who otherwise would not qualify for ICD, such as class 4. Use of inotropic plan to discharge on ICD is reasonable. It's a 2A, and similarly for a 2A indication 2A is LVAD with sustained VA ventricular arrhythmia. ICD can be beneficial. ICD use after heart transplant is also listed in patients with probably starting to have dysfunctional graft or severe allograft vasculopathy. So this is the primary prevention of sudden cardiac ischemic heart disease in the flow diagram form. I went through the fundamental class 1 and 2, non-sustained VT with ejection fraction 40% inducible VT, and those with conventional class 4 but eligible for advanced heart failure therapy. On top of that, if those patients have recurrent VA, there are also criteria of under indication 1 of using medical therapy or catheter ablation. However, for recurrent VA with ischemic heart disease, again, in patient in excessive VT or VF, an ICD should not be implanted until sufficient control VA is achieved to prevent repeated ICD shock. So this is a harmful class 3 indication. On top of that, they also have a reminder that if patients with ischemic heart disease sustained monomorphic VT, coronary revascularization alone is an ineffective therapy to prevent recurrent VT. Now we change to non-ischemic cardiomyopathy. Similar to the ischemic cardiomyopathy group, if for secondary prevention are those who have documented abort sudden cardiac arrest due to VT-VF or hemodynamic unstable VT. For 2A is a non-ischemic cardiomyopathy with syncope presumed due to VA who do not meet the prime indication for primary prevention ICD. Sometimes we consider, if you are considering ICD or even an electrophysiological study for risk stratification may be beneficial. For those who survive a cardiac due to limited life expectancy or functional status, amiodarone is to be considered for prevention sudden cardiac death. So 2B for this indication if you have to consider oral medical therapy for those who are eligible for ICD. Coming to primary prevention of non-ischemic cardiomyopathy, similar to the ischemic class, but this only include class 2 to 3 New York functional with ejection fraction 35% despite GDMT. So this is given a class 1 indication. And then under 2A, they look into patients with lemon AC mutation who have 2 or more risk factors, such as non-sustained VT, ejection fraction less than 45%, non-missense mutation, and male sex. So ICD can be beneficial in this group with a genetic condition of lemon AC mutation and ongoing left ventricular dysfunction. Functional class 1 is given the 2B in this guideline with ejection fraction less than 35%. And for those who are medication refractory heart failure, functional class 4, who are not candidates for any advanced heart failure therapy, such as heart transplant, LVAD, or even CRT defibrillator, ICD should not be implanted. So advanced heart failure class 4, not eligible advanced heart failure therapy is given a functional class 3. So for those with the recurrent VA in the non-ischemic group, again, amiodarone, sotalol can be considered, and beta blocker, and the catheter ablation. Both of these receive a 2A indication for recurrent VA in patients with non-ischemic cardiomyopathy. So in this flow chart in the guideline, they have incorporate both secondary and primary prevention. It looks a bit busy, but if you're following the squares consecutively, it's actually pretty well defined in this flow diagram. How about the European guideline? This table actually gives us a direct comparison of the ESC guideline and the US guideline. Essentially, New York Functional Class 1 and non-sustained VT and inducible VT during electrophysiology study is not recommended in the ESC guideline. But it was this kind of Class 1 and the class 1A and class 1B respectively in the USA guideline. The time and a reasonable expectation of meaningful survival of more than 1 year. And this including patient with ischemic and non-ischemic cardiomyopathy, reduction in mortality from ICD ranges from 23 to 55%. As a result, over the past decades, primary prevention of sudden cardiac death has become important part of management of high-risk patients with severe left ventricular dysfunction. But as time goes by, actually with evolution of technology practice, we are seeing changes in technology and clinical practice over on the possible guideline-based recommendation. So essentially, from strategy to reality, it's challenging to generalize finding from randomized clinical trials to clinical practice in the real world, because we are seeing different groups of patients. And we all know that patients in the elderly group, patients have other comorbidities such as chronic renal disease or other comorbidities. Most of them are not included in the controls setting of the clinical trials previously used to establish our clinical guidelines. For example, using the non-ischemic cardiomyopathy, is actually there's a paucity of data. The current guideline recommendation for primary prevention in non-ischemic cardiomyopathy are mostly based on the meta-analysis of small trial or sub-band analysis in the large trial, such as SCUT-HF. Medical therapy and CRT have changed dramatically the prognosis and outcome of patients with heart failure and non-ischemic cardiomyopathy, and in face of important reduction in role of non-selective ICD implantation in non-ischemic cardiomyopathy. Sorry, my typo is currently debatable. This comes from the Dana study. This study was published in 2016, just about 4 years ago, looking into ICD implantation in patients with non-ischemic systolic heart failure. They have randomized patients on to non-ischemic cardiomyopathy and to already on medical therapy and CRT. They randomly assigned from ICD to no ICD, and the primary outcome is all cause of death, a secondary outcome of sudden cardiac death and cardiovascular death. And in this group of patients, the overall left ventricular ejection is very poor, 25%. The QRS overall average is prolonged in 146. And you can see that this is a study with a very, very high compliance to our standard heart failure regime. The ACEI or ARB percentage is approaching 97%, as well as beta blockers approaching 92%. And just under 60% of this group of patients receive a CRT. So this group of patients reflecting more of a nowadays guideline-based heart failure patient. And in this report, there's no difference in all-cause mortality in the Danish study. Even look at the secondary outcome, there is a reduction of sudden cardiac death in ICD group, but for cardiovascular death, 31% were actually not cardiovascular, and the arrhythmia event rate was lower than predicted. And there's no difference in patients with or without CRT therapy. But out of this study, if they look into further sub-analysis, they identify that patients of the age of less than 60 years old actually will derive benefit from ICD therapy. So this actually highlights the need for risk stratification tests outside of just LVEF to identify subgroups with non-ischemic cardiomyopathy or multiple medical therapy who benefit from an ICD. The 2017 guideline actually acknowledged Danish study, and but they actually go on further said that there's other meta-analysis which, however, does favor ICD in non-ischemic cardiomyopathy, and that's why they still keep the current recommendation as stated. Another study just published for the prolonged long-term follow-up of the SCUT-HEF trial just earlier this year in the JACC. They also find that the long-term ICD benefits vary according to the heart failure etiology and New York functional class. And the most benefit comes from those who are ischemic heart failure patient and those who are New York functional class 2 symptom at trial enrollment. So interestingly, beyond year 10 of ICD therapy, both the ICD and the amiodarone seems to converge together and have the similar results after on long-term follow-up. So the question of whether can just use left ejection fraction alone parameters for arrhythmia risk stratification. We know that not all patients with low ejection fractions, including the original legacy, derive benefit from primary prevention. Lack of appropriate therapy in majority of patients with primary prevention ICD before dying of heart failure or other arrhythmic cause. And yet more than 50% occurrence of sudden cardiac death in normal, mild, or moderate depressed ejection fraction more than 35%. So this, I think, I'm sure our panelists or the cardiologists do have similar experience of what we are facing currently right now in the real clinical practice. And what's more, changing outlook of our heart failure patients because of the new therapy or additional CRT and appropriate revascularization patients. And remember, the current indications for implanting ICD for primary prevention of sudden cardiac death was based on clinical trials 15, 20 years ago. Diagram is very interesting. Actually, it shows it's an analysis of over 40,000 patients with HFrEF enrolled in 12 non-ICD clinical trials. As a result of gradual introduction of ACEI, ARB, beta blockers, mineralocorticoid receptor blockers of subsequent drugs, the significant reduction of 44% in rates of cardiac death across this trial was observed. And the annual rate of sudden death per 100 patient year decreased from 5.4 to 3 in the long term. So this actually may have some impact on our further stratification of heart failure patients. So the question is there still survival benefit of primary prevention ICD in systolic heart failure? After the publication of the Danish trial, lots and lots of meta-analysis based on these questions was published. So looking at the ischemic versus non-ischemic, here the Danish trial is also included in the non-ischemic cardiomyopathy. This shows does have some benefits in ICD therapy. Another published in the BMJ Open of 5 randomized controlled trials of 2,500 patients or so. Again, they look at it seems under all groups, mortality benefits are again in the whole spectrum of patients in ICD therapy. Other meta-analysis show here, again, significant 23 reduction of all-cause mortality to 25% in these 2 studies. So it is in the guideline that stated that although the Danish trial does have significant results, based on all these meta-analysis, they still keep the current indication in non-ischemic cardiomyopathy. Other risk stratification have been proposed and put forward, such as MRI imaging for the scar imaging and risk stratification. This is another meta-analysis published from the Korean journals, again showing some benefits of CMR identification. And some of the recommendation proposed, other than identify myocardial fibrosis, you go use a biomarker such as the CRP and NT-proBNP. The rest of the guidelines actually go on to other clinical entities of management of ventricular arrhythmia as shown here. I'll go through very quickly through the slides, showing you the RVD. This is again very detailed from investigation management, and this is the one on the ICD therapy. Hypertrophic cardiomyopathy. If this is a frequently encountered clinical problems, and do read through the guideline because they do write out, bring out very in details. Again, no benefit of during an electrophysiology study, and in those with the identified genotype, but absence of sudden cardiac risk, ICD should not be implanted. Others would be long QT syndrome shown here, Brugada syndromes. Adult congenital heart disease, another group that we should not forget, because they do have high risk of, some of them have high risk of frequent VAs, especially the TOF being mentioned here, and TOF who presented with syncope and ventricular dysfunction. They do also go on to talk about other transvenous ICD rather than transvenous ICD, such as the subcutaneous implantable cardioverter defibrillator. They got their criteria here, such as inadequate vascular access at high risk for infection or pacing for bradyvity, or pump of CRT is not needed. And the other one is the wearable cardioverter defibrillator. I don't think it's currently available, or maybe in isolated unit overall in the Asia region. But it's really for those who are considered at risk of sudden cardiac death, but beyond the, but with still not with out of the 40 days from an MI or post 90 days after revascularization. Or those who require removal ICD but still at risk. So these are the 2 non-transvenous ICD recommendations from the. Also, terminal care is essential for the patient with severe heart failure and not eligible. And the other thing they talk about is ICD termination at the end of life care. So this is also quite important, and this is outlined in the guideline as well. So the following actually is the last paragraph from the guideline, and they do recognize and acknowledge evidence of gaps and future research needs. Information on the subgroup not represented in the pivotal ICD groups, as I mentioned. High risk of identification and treatment of high risk of sudden cardiac death, not identified by current ICD eligible criteria, and better risk stratification. So they have whole lots, but I pick out some regard with specific reference to ICD therapy. Find high risk patients with requiring of sudden cardiac death with appropriate ICD therapy. This is another algorithm published just earlier this year regarding ICD candidate, but I'm sure the rest of the speaker on today or in the next ICD lecture will go through this in more detail with you. So in conclusion, what is clear is that ejection fraction alone is likely not enough to make judgment regarding the ICD implantation. We need more information of long-term mortality when defining prognostic utility using risk score or future study or trials. Without this data, I'm afraid practice guideline will remain unchanged, and it will be hard, if not impossible, to deny eligible patients the option of ICD implantation. So future efforts should be focused on refined methods of selecting patients at risk of preventable sudden cardiac death more simply than just left ejection fraction. It's crucial for the development of cost-effective prophylactic ICD therapy aimed at closing the gap between scientific evidence and the limited resource of a healthcare system worldwide. So finally, just the last advice. Guidelines are here to guide, but patients and physicians decide. So informed decision-making is very important between you and the patients when deciding ICD implantation. Thank you very much for your attention. Thank you.
Thank you very much, Dr. Fan, for your clear and informative lectures on
advice or guidance on how to go about recommending ICDs or not. But I completely agree with Prof. Fan in her closing remarks that at the end of the day, guidelines are simply guidelines. We really need to sit down and discuss with our patients, and especially in Singapore's context, patients' family members as well, to discuss the risks and benefits of ICD implantation as well as the follow-up. So that's in a nutshell how we practice in Singapore.
Thank you.
Thank you.
Prof. Fan, I think we have one question from a participant. In your own personal practice, are there any specific patient groups that you would definitely recommend a primary prevention ICD?
Well, I do have a lot of, I do look after a lot of heart failure patients as well. And it's always a mixed feeling when you try to refer up to the guideline and then the paper, and then you got the other rest of the studies. But I think the heart failure patients do have risk, and but especially in the less severe of the functional class 2 or 3, because by the time they reach class 4, their mode of death probably switch from ventricular arrhythmia, sudden cardiac death to pump failure. So sometimes it's quite difficult to convince the patient who are in group 2 of, well, mainly group 2 actually, that they need an ICD for protection. But I do put an ICD in more heart failure patients, definitely.
Okay. We have another question from a participant. In your practice, is there any particular score that you use with regards to estimating 1-year longevity in your patients prior to deciding whether to implant an ICD or not?
Well, there are the recommendation using the heart failure score, and if you use the Seattle heart failure score, they actually, if by adding the ICD or other device therapy, actually they can change the estimation quite significantly. So sometimes I do use the heart failure score to discuss with them and show them the sort of the overall data. But again, at the end of the day, is really you have to sit down and discuss with the patients and the family the indication of the ICD, I think.
Okay.
Thanks very much.
Thank you very much, Prof. Fan. I think, Jeremy, shall we move on to the last speaker?
Yes, great. Thanks. So let me share the screen again for our Next speaker.